Well, hey there. Good afternoon. Guess what time it is? 4 o'clock in the mountain time, which means 6 o'clock on the East Coast, 5 o'clock in the central, 3 o'clock in the mountains. Boy, see, I'm getting good at this. I'm Dr. Randy Fink, and welcome. Fertility with Fink and Friends. I am Fink, you are friends, and I'm the clinical director of IVF services here at CNY Fertility in Colorado. And we, like every Tuesday evening at this time, get together to talk about fertility and women's health. Try to get all your questions in here and spend a little time together. It's my favorite time of the week, and I sure hope you enjoy it as much as I do. How was your weekend? How is your week going so far? Tuesday, we're almost half the way done with the week, almost at the old hump day. Let's see who we've got on here. I see my beautiful mother, Bama Gal. Thank you for being here. Mom and Dad in scenic Mobile, Alabama. Glad to see you here today. Anderson JX, you are number one over here on my Instagram side here. Hey to Mariah and Ashley. Kelsey and Rachel, David, Lex Blackwell, good afternoon. Kayla Thompson, Kristen Girl, Jackie Drew, and Dawn Deluxe. JM Dots, hey, good to see you too. We've got, let's see, this is my Instagram here. We've got LinkedIn, Facebook, and YouTube right here in the middle. We've got 20 folks on Facebook there already. We've got Tony, Jessica, and Neri saying hello. And right here on CNY's Instagram, Dr. Goodnuts is the first. Thanks for being here. You get a special hello. Sarah Beth, Exo Bellissima, nice to see you here. Nika 1219, Brooker Johnson, Selena, hi to Faith, good to see you back here. Haven't seen you for a while. Sister Coyote. Let's see, that looks like Jennifer, I can't see what that says, Jennifer, but she said hello. So a special hello to you. Thanks for being here today. Hi, Florida Babe. Hi, Hala Blaney, Liz. Nice list of folks here today. So let's see if we can't jump right into some questions, shall we, and see what we can accomplish. Been kind of a neat, and I have to send, in addition to a special hello to Mom and Dad in Mobile, Alabama, special hi to Brandis Montez, our wonderful nurse practitioner here at CNY Fertility, Colorado, who is kind enough to join. Brandis is actually going to be joining us in the studio here next week. Fertility with Fink and Friends will actually have a friend in studio. So how about that? Okay, let's see. I had a couple of questions. I had a few questions from people who asked from home, and I want to get to these. And I brought a little visual here for one of them. The first was exactly what is my pap smear and does it have anything to do with my fertility? So does it have anything to do with fertility? Yes, it has something to do with fertility, but not directly. The pap smear is a screening test for precancers of the cervix. The recommendations are always changing as to how often you should have a pap smear, but the pap smear is a very simple test, should take seconds to perform. Gosh, sometimes I'll do a pap and people and they'll say, oh my goodness, my doctor, my primary, so it takes 15 minutes to get my pap done. It should take, seconds. Here's what a pap smear is. So first of all, it goes into this vial, and you can see what's in the vial here is that it's liquid. The old type of pap smears, so remember this, remember back in like second grade, you could take a Q-tip and scrape the inside of your cheek. And you could smear that stuff on a microscope slide, and that's how you learn kind of what a cell looked like. Those are cells, and you see them under the microscope. Well, it's kind of doing the same thing from the cervix, because we can get precancers on the cervix just like we can get precancers on the skin from the sun. And what the pap smear does is that it tests for those precancers. Cancer of the cervix, cervical cancer, is really a preventable disease. And that's because we've become so good at being able to test for it. We're really very adept at the testing and how to manage the abnormal pap smears, how to diagnose the area that caused the pap to be abnormal, and then knowing how to follow those problems. So this is a little brush. This is the brush that's used, or they call it a broom, actually, used to do the pap smear. So the cervix is the opening to the uterus, and it kind of looks a little something like this at the top of the vagina. We take the broom and it goes here and it just turns around like so. And what that's doing is that it's just like that toothpick inside your cheek. It's taking off some cells from the cervix itself. This little broom, you can see, so it's got this tip on the middle, and that's because it's going inside the opening there. Let's see if I can show you, right? So that it's getting cells from both the area around the outside of the cervix and from the inside, or what we call the endocervix. The little broom then goes into the jar where it's swished around. Those cells are washed into that liquid. And then when the pap smear is sent off to the laboratory, it's processed through a machine to separate out the liquid, to separate out the cells, to separate out the white blood cells and the bacteria and whatever else may be there, so they can just look at the cells that came from the cervix. That's what a pap smear is. An abnormal pap smear does not stop you from having a fertility treatment, nor does it increase having an abnormal pap smear in general does not increase your risk for infertility or for fertility concerns. So if you've had an abnormal pap, you're fine to follow it. You're fine to have a colposcopy, which is the procedure that we do to look at the cervix with like a little microscope to see if we can find the area that caused the pap to be abnormal. Fine to do all that. So pap smear should not be a big worry for you, but we do want to make sure that you're up to date with your paps because that screening test is so important enough that we really can prevent folks from developing cervical cancer. Another question came about, and it was really about the difference between HCG-LH and the medicine known as Menopur. And the person asking the question was concerned that she had read online that Menopur is a very, very strong medicine and can, quote unquote, fry the eggs. So fried eggs is not really a thing. People talk about that all the time, but there's not really a scientific entity other than what happens in your kitchen, where your eggs get fried, unless they're coming from the fridge. So you don't have to worry too much about fried eggs. Menopur is a different medication. Menopur is a combination of both the FSH hormone and the LH hormone. So yes, it's a strong medication, but when we use Menopur, we typically decrease the amount of the follistim organelle F that you're using. So that all balances out. The data shows us that the HCG LH is a fine medication in IVF for many people, and it is considerably less expensive. It's probably 140, 150, something like that for the whole vial of HCG, whereas the Menopur is about $80 per day. So it adds up a lot faster, the Menopur. We may get better egg quality. We may get fewer eggs, but better egg quality with Menopur, and that's why we will sometimes opt to use it. We at CNY will usually start with HCG-LH because the cost is so much lower, and for most people, it's really just fine. It does just fine, but Menopur may give us better egg quality. So if we had some experience with you in your cycle, where there were concerns about egg quality, that's when we might talk about switching you to Menopur. Unfortunately, it does mean a little higher cost, but sometimes that's worth it to get the better result. Let's see here. Hi to Zinni in Miami, a special hello. And let's see. I saw somebody got pregnant here. Who was that? Somebody said, oh well, I thought I saw somebody. Brandis is telling somebody congratulations. So I hope that means somebody's pregnant. Shabnam says, I transferred an untested embryo and I was taking tacrolimus 1 milligram. Does that help implant abnormal embryos as well? Because I heard genetically abnormal embryos do not implant. Okay, so you bring up two very important points. And the first is we've talked about tacrolimus in the last couple of weeks. I had a posting about tacrolimus up, and this is some new data that I feel very strongly about, that we've kind of learned one of the reasons that folks have recurrent implantation failure. And that is when doing IVF, you keep putting embryos in when they should be sticking and they're not. We've learned that it has to do with something called T helper cells at the level of the endometrium, which is where basically the embryo is trying to implant. One of the reasons this can keep failing is because you've got an abnormality with your T helper cells. And so when we use the medicine that's called Prograf or tacrolimus, at a dose of 3 milligrams per day, and that's important because the study looked at the different doses and found that, yep, it's the 3 milligram dose that really is what does it. So if you were on a 0.5 milligram twice a day, not enough. We want to go to either a 1 and a 0.5, which are two separate pills. So 1.5 milligrams twice a day, or you can take the 1 milligram capsule and use it 3 times daily. So that 3 milligram dose of tacrolimus will prevent the body from rejecting the embryo like it was an organ transplant. So if that indeed is the problem, then we can kind of fix that with tacrolimus. And so extrapolating that, we're putting a lot of people who are part of our Immune 3 protocol on tacrolimus at that dose because maybe we don't know that they have that problem yet, and we don't want to find out. We'd rather them just get pregnant. So that's how that works. Will it let an abnormal embryo implant? I think the answer to that is probably no, because the abnormal embryo sends some different kinds of messages to the endometrium, which tells it, no, this one is not right. So that's why in IVF terms, in most cases, abnormal embryos don't implant. They won't continue to grow. But very good question there. Let's see. I want to know. Lex Blackwell said, how long should I continue keto? Oh, that was the positive beta. There we go. Lex Blackwell. How long should I continue keto after a positive beta? Thank you, Brandis. Congratulations, Lex. Yes, indeed. So if you ask Dr. Kiltz, he'll say stay on keto. There are lots of thoughts about diet. Dr. Kiltz's work is in keto and carnivore, and he feels very strongly that that is the right thing for everybody. So I would say there's little reason not to stay on it now. Lex, congratulations. Boy, that is some great news. Sure happy to hear it. A special hello also to Lexi Lorente at the beautiful Miami Center of Excellence, a wonderful place to monitor and for women's health in South Florida for anyone who is in that neighborhood. M. Klein says, ready for our 5th embryo transfer. Recently saw you started using Prograf. How is that used? Well, hopefully you just answered the question there. I would like you to be on 1.5 milligrams twice a day or 1 milligram 3 times a day, especially for you, M. Klein, because you definitely fit into the criteria where, God willing, that will make a difference. Hi again to all the folks over here on the CNY side. Crystal Haybor says, I had my blood drawn for a beta today at the Atlanta Clinic. Won't get results until tomorrow. Thankful for all of you at CNY. That is such a nervous time, getting the beta and waiting for the result, or worse yet, getting a positive beta and then waiting to see it kind of go up. And yeah, every day is a new click on that little roller coaster ride. So fingers crossed there, Crystal, and thanks for being with me here this afternoon. Broker Johnson said, why would a doctor choose a natural FET versus a medicated FET? And that's a very good question too. So the medicated cycle was really what they have been using in IVF since it was invented. So since IVF first came around, like 40 years ago or so, medicated cycles have been what they've done. And why is that? Well, we give you all the hormone. We shut down your body's ability to make that hormone so that we are really controlling every aspect, all the variables of your hormones. And that way, there's no guesswork involved. We are in complete control. A natural cycle is when we let your own hormones take a front seat so that you are making the hormones. Instead of giving you estradiol orally and vaginally, we let your body build a follicle, and that follicle secretes estrogen, and that estrogen thickens up your lining like it does every other month, even when you're trying not to get pregnant. When that follicle is of a sufficient size, we can trigger the ovulation, which tells the ovary to release the egg. When it does that, that starts the clock ticking on when you're going to have your embryo transfer. But when the ovary releases the egg, your body starts to make your own progesterone, which means that you don't have to get the progesterone in oil shot. Big plus there, right? No PIO shot. We use a little vaginal progesterone just as a local effect because it helps. So it's said that a natural cycle or a modified natural. And by the way, it's a little bit of a misnomer because some people think that when we say, oh, you're going to do a natural cycle, that it means we're not going to do any monitoring. That we're going to say, okay, well, here's your embryo, call us when you have a birthday party. And that is not the way it works. We still do all the monitoring. We still check all the blood tests. If you need extra hormone, we will give you extra hormone. But instead of giving you all synthetic hormone, we are letting your body's hormone take the lead. And that's what a natural cycle is. There is the evidence shows us that there is that they are at least equivalent. But there is some evidence that says that the natural cycle, or even a modified natural cycle, which is where we give you some ovulation induction, like a little letrozole to make sure that you're going to release the egg, has a lower miscarriage rate, has a higher ongoing pregnancy rate, and has a lower risk of certain pregnancy complications, specifically blood pressure complications down the road. So I favor modified natural cycles. I think it's great because I think people's butts don't need to have all that progesterone and oil. It is our least favorite injection in the whole IVF business, as anybody who's been through it can tell you. There's some people who say, I don't mind. I'd rather just do it than not do it. In which case, okay, that's fine too. But most people don't love doing the PIO. And so it gives you the ability not to have to do that and let your own hormones take the lead, and may just have a little higher success rate. Scarlett says, what does a high AMH mean before starting IVF? So a high AMH or anti-Mullerian hormone is associated with polycystic ovarian syndrome. Or at least what we call polycystic ovaries. And in general, what that means for IVF is that if your AMH is high, so the way we dose the medications like your Follistim or your Gonalef, sometimes your Menopur, and even the HCG/LH, the way we dose those is really dependent upon your age as a primary factor, because your age is going to tell us how we expect your ovaries to respond, with a secondary measure being the AMH. So if the AMH is high, that tells me your ovaries are going to pay really close attention to the medication. So you're probably going to make a lot of eggs. So if the AMH is high, we will usually lower the stimulation dose so as not to get you hyper stimulated. It just tells us how the body is going to respond, and it usually means that you're going to respond really well. Scarlett, that's not a bad problem to have. Let's see who's over here on Facebook. Hi to all my friends on Facebook. First up was Tony Collins. Looks like Tori Collins. Tori says, I was told at follow-up the day after retrieval to sit this next cycle out since I had some fluid on my right ovary and had some OHSS, but I feel fine now and reached out to the Colorado nursing team. They told me I was okay to proceed with an FET if I choose to today at cycle day 1. Should I sit this cycle out and let my body rest, or do you think I'm okay to proceed? 18 eggs retrieved, and you ended up with 15 blasts. Tori, that is awesome. Boy, that's a really good result. Really, once you have your period, what's happening there is that you are sloughing off that lining, you're rebooting the system, and you should be fine to continue. If you had a little bit of fluid inside, I would say, that can also be physiologic. People who didn't go through an IVF stimulation and potentially have ovarian hyperstimulation syndrome, or OHSS, can have fluid inside, under normal circumstances. So, if you still have a lot of fluid inside, if you're still feeling really bloated, well, that's a different story. But in general, once you have that period, you're sloughing off the lining, you're cleaning everything out, and you should be ready to go ahead. So I think you're probably okay to start, even if you had OHSS in the cycle that you just finished. Getting your period now, I think you can in most cases proceed with your frozen embryo transfer. We'll look forward to seeing you. Tori Jessica says, I'm 14 days past an egg retrieval with a double Lupron trigger and no HCG, and I still have not started my period. Should I be worried? Also, do you recommend patients with a high number of eggs wait to do an FET until after the next cycle? Well, I think we just answered that part there, Jessica. You should get a period. So the Lupron makes you ovulate. And so typically you enter a luteal phase there. You're probably making a lot of progesterone, and it may just take a little time for that progesterone to wear off to get you to have the period. Unless, what's that other reason that sometimes people don't have periods? Oh, yeah, there's that pregnancy thing. So I talked to a patient last week who was told that she had tubal factor infertility. She was told that both of her tubes were blocked. And so they did IVF, and she did a freeze all of her embryos, or maybe she did PGT testing. So the embryos, she was not doing a fresh transfer. After, or maybe just before their egg retrieval, they had intercourse. And even though we did not have we did not do an embryo transfer, but she is pregnant with spontaneous twins. So apparently the tubes may have been blocked, but there was enough room there that 2 sperm got through and found a couple of eggs to fertilize. And so it would not be inconceivable, Jessica, that you could be pregnant. So I would do a pregnancy test for sure. But otherwise, if you're not pregnant, then usually what that means is that you're making a lot of progesterone from all those follicles, and it just hasn't dropped off yet, which is the signal that gives your body, tells your body to have that period. My guess is within a day or two. Neri is here. Would you recommend taking Prograf with the very first frozen transfer instead of waiting until there are multiple failed transfers? Well, so the evidence, so the American Society of Reproductive Medicine says that there is no reason that folks without a history should be on medications for immune things without that history to support it. In my opinion, I probably would do it because I agree. Why do we want to wait for you to have multiple implantation failures if you're one of those people whose ratio of T helper 1 to T helper 2 is off? I would say, it's a safe medication to take in pregnancy. They give it to women, who have had organ transplants, like kidney transplants, who then get pregnant. So it's believed to be safe. It's generic. It's not expensive, and has most people don't complain about side effects. So, Neri, I'd say I think it's worthwhile doing. Brittany is, or actually, is that Brittanilli on the CNY side here, said the HSG and the saline sono showed a heart-shaped uterus. Oh, that's so sweet. Laparoscopy and hysteroscopy is scheduled. How long should I expect? Isn't that funny? I made a little heart, and there was a bunch of hearts that just blew up, I guess. Let me see if I do that again. Did that work? No. Oh, yeah, and there, it did it over there. That's kind of cool. How long should I expect to recover before doing medicated cycles? So after a laparoscopy and a hysteroscopy, generally speaking, well, if you are, it depends on what they're going to do there, because if you have a uterine septum, which is a band of muscle that runs down the middle of the cavity, and that's what's going to be fixed, then I think that you probably want to wait a couple of months before doing an embryo transfer cycle to let that, probably 8 weeks to let that heal. If they're just taking a look to make sure there's nothing else going on, you should be able to proceed in your very next cycle. Hi to Coco Diva, like that. Hala Blaney, Hala. What do you think about NAPRO? Don't know what that is, I'm afraid. Let's see. They stopped my IUI because my FSH. What does that even mean at my old fertility clinic? I'm switching to CNY. Next week is my first appointment. Okay, well, so they stopped my IUI because of my FSH. So if your FSH level is very high, this is the way that works. Low estrogen levels mean high FSH levels. High estrogen or normal estrogen means lower FSH levels. So what happens in menopause? Is your estrogen high or low? In menopause, your estrogen is low, right? Menopausal women have low estrogen levels, and that's what causes the hot flashes and the vaginal dryness and all those things that go along with it. So low estrogen, high FSH. Sometimes we will see on folks on baseline labs that people have a high FSH level. And if that's the case, then we know that the typical medications that we're going to use are not going to work, because pretty much everything that we're doing to try to get you to recruit eggs is designed to increase your FSH level, so that FSH stands for follicle stimulating hormone. And if your FSH level is already very high, then giving you something to try to make more FSH is not going to fix the problem at the level of the ovary. So Jean Telato, I'm sorry, I can't pronounce the name. My guess is that's what happened there. There are some things that we can do to try to lower that FSH. Now, if naturally your FSH has gone up because you have no remaining ovarian reserve, like there's not any eggs left in the ovary, we can't put eggs back in the ovary, but assuming there's something there, there is some hormonal manipulation we can do to try to lower that FSH so that we can stimulate you to try to get a response. This also begs a question that I was asked over Instagram, and that is, what about, in my previous cycle, I started off with having a follicle count, or an AFC, an antral follicle count, which means the way the follicles look in the ovary kind of before you start doing anything at the beginning of the cycle, was 10. Then I did a cycle, and at the next one, the AFC was only about 3. Does that mean that I shouldn't be doing another stim? My answer to that is, well, if an AFC of 3 is considered to be a low number. However, we don't really use the antral follicle count for anything definitive anymore, because the AMH is really a much better predictor of how you're going to respond to your stimulation. So I would not necessarily let that be a guide, especially if you just finished a cycle and you're about to go into another one, because doing a back-to-back or a stacked cycle generally always gets us better results. So hopefully that's helpful news for you there. Oh, yeah. Okay. JM Dot says, oh, yeah, going back to the pap smear, treatments and procedures for abnormal cervical cells are so not a big deal. No excuses not to get it checked out. Nobody likes getting it done. Nobody likes going to have a checkup. The pap smear is always, I always say this is our most popular exam. I say it is your favorite position with your favorite physician. right? Yeah, I'm glad you do it. It is important work. People love you and people count on you, and that's why you do it, even though nobody really likes it. Let's see. If I've had endo removed and still having issues with implantation, would you suggest down regulation or could you do birth control for a month? Well, I think it depends. And this goes to looks like Nikan, I think. If the endo was removed recently, I would consider down regulation. I think, is probably empirically what I would say is my gestalt there without knowing the details of the history. I would rather see you do that. Using birth control for a month is not likely to make a big difference there as far as recurrent implantation failure. Birth control for embryo transfers is really just kind of to help batch, to deal with timing. So I would think down regulation for endometriosis is probably a better bet. Hi to Dr. Jovi. Hi to Leah. Nice to see you here again today. Nice to talk to you yesterday. Does IVIG or an endo scratch help with implantation? So IVIG, intravenous immunoglobulin, is one thing that we can do for people who have recurrent pregnancy loss or recurrent implantation failure, but it's very, very expensive, and there's not great evidence that it works. Why do we use it? Well, because it's kind of the biggest immunologic gun there is. That is to say, it shuts down things that we don't even understand. So things that we can't test for, it really, helps to suppress an immune response that may be something either we can't diagnose or don't know how to diagnose. And so there are many cases where IVIG is a good thing. An endometrial scratch, which is where you use a little instrument to take a little endometrial biopsy and scratch in the lining, has not been shown to improve the pregnancy rates. And so I'm always very hesitant to suggest that to someone unless they're really out of other options and we just don't know what else we're supposed to be doing. But people with recurrent implantation failure, the first thing I think about is, when was your uterine cavity evaluated? You need either a saline sonogram or a hysteroscopy, and I say you do it once a year. You need to evaluate that cavity. You have invested a lot into making those beautiful little embryos. Don't put them in unless you know that uterine cavity is normal. Very strongly about that. Number two, I think a receptiva is a great test because do you have endometriosis, silent endometriosis that may be standing in the way of your embryos implanting? We can test for that marker that's called BCL6 that interferes with the way the brain is talking to the uterus. It stops you from being able to implant. And if that's positive, then we suppress that endometriosis for 60 days. And lo and behold, you do amazingly afterwards. Do you have that problem we talked about with your T helper cells that we can just treat with Prograf, 1.5 milligrams or 3 milligrams total divided up during the day? I would look at those things before thinking about IVIG because it's so expensive and because it's not well proven as to exactly what it does. And I would skip the endometrial scratch. If I have Menopur from a previous IUI, should I use that instead of HCG LH for my bundle? Absolutely. Jenny, if you have, so first of all, to use Menopur in an IUI, to me doesn't make a whole lot of sense because the pregnancy rate with an IUI is about 9% or so per cycle. And so if you're going to spend that much money on medication, I think for sure I recommend that you do something that's going to give you a very significant pregnancy rate. And that would be something like IVF, where you may have up to a 65% probability of pregnancy per embryo, not even 9% per cycle. But yes, if you have Menopur from before, please use Menopur instead of your HCG LH. Absolutely, positively. Lacey is on the Facebook side. Hi to Lacey. Hi to Gabriella. When do you recommend a natural modified? It's my go-to. So if you talk to me, that's probably what I'm going to order for you. It may not be, and it is in fact something that you can ask for. The default for embryo transfer is always going to be a medicated cycle. So if you don't say anything, it's going to be a medicated cycle. But you can always ask for a natural or a modified natural cycle. The only caveat there is that if you don't have periods on your own, if your hormone levels are not right, then I would say you may be better off with a medicated cycle. But Brittany is here as well. Let's see. I think we talked about that. Gabrielle says, I have my hysteroscopy with Dr. Fink next week. Wonder if I can do a natural modified right after. You can do it in the next cycle, but you can't do an embryo transfer in a cycle when we're doing a hysteroscopy. We don't want anything touching the lining of the uterus when you're going to put an embryo in there. Right? Ariel is with us on Facebook, delivering my CNY baby on Friday, taking him at 38 weeks. Okay, congratulations, Ariel. Boy, that is awesome. And boy, things are going to change at home pretty soon, right? That's fantastic. Alicia is with us on Facebook as well, going into my third egg retrieval, 4 unsuccessful transfers. And our insurance finally is covering now. Woohoo! Boy, insurance, don't get me started about insurance. Insurance is finally covering. Can I do back-to-back egg retrievals, hoping to bank embryos this time around? Strongly recommended. So a back-to-back cycle is, let's say that here we are in April, and let's say you do a retrieval. You do your retrieval, 10 days or so later, you get your period, and you start on your next stem. That's a stacked cycle or a back-to-back cycle. And typically when we do that, especially repeatedly, one way to think about it is that, well, your body knows what it's supposed to be doing. And so it may just do it better. But in reality, what's happening there is the medication that we use in the first stem will continue to help you in subsequent months, probably for about 2 to 3 months. So each month that you do a back-to-back, you should get steadily improving outcomes, if not in outright numbers, then at least for sure in egg quality. So back-to-back, strongly recommended. Anne asks, do you have women whose pregnancy has depended on progesterone? Well, so certainly in the fertility world, we will always give you extra progesterone in that luteal phase. By the time you make it to about 9 weeks pregnant, the placenta will take over for making progesterone. So there are many people, especially with spontaneous pregnancies, who have a problem with their luteal phase where they may not be making enough progesterone. Now, that's a hard thing to say because unhealthy pregnancies will cause you to have a low progesterone level. And every single day, I talk to people who say, well, I had a miscarriage and we checked my blood and my progesterone was low. Well, a miscarriage is certainly more likely due to a genetic reason, a chromosomal problem with pregnancy. And an unhealthy pregnancy doesn't have enough progesterone. And so it's more likely that an unhealthy pregnancy causes the low progesterone rather than a low progesterone causing an unhealthy pregnancy, if that makes sense. Let's see what we got here. Amori Jordan says, when doing IVF, should you get chickenpox vaccine? And I would say, I would, do it before you get pregnant. If you are the chickenpox is the varicella virus. If you are varicella non-immune, then absolutely get a vaccine, because contracting chickenpox during pregnancy can be catastrophic on an embryo and actually has a reasonably high death rate in mom, especially if you get what's known as varicella pneumonia. So it's a non-controversial vaccine. It doesn't cause any known problems. It's been around. It's considered safe. So yeah, that's one of the reasons that we check. We check rubella because congenital rubella is similarly devastating. And that vaccine, almost all of us got as children. It's called an MMR. measles, mumps, and rubella. We check the rubella and we check the varicella because if you're negative, definitely recommended that you get vaccinated before you get pregnant. Exobelisema, my last cycles for IUI with a different doctor had me on 150 gonal and 30 of HCG. Lining got to 10 with numerous dominant follicles on both sides, even though the left side isn't connected due to a unicornuate uterus. I just wouldn't do that. 150 of gonal and 30 of HCG. That's a lot of HCG for that low dose of gonal. But in that situation, you make a lot of follicles. And so you may get triggered and released a lot of eggs, and then suddenly you're putting 15 million sperm in there with a lot of eggs getting released. And that's how bad things happen, like multiples, like higher order multiples. Plus, again, just the cost of those injectables is so high. To me, well, if you're at a place where that IVF is going to be costing you, $30,000, $40,000, even $20,000, then yeah, you do all the IUI you can do because you don't want to have to pay the other thing. But gosh, at CNY at $39.95 for a cycle of IVF, to me, it's hard to really justify IUI at all because the success rates are so much higher with IVF. But for people who want to do it, you do it, but you just limit yourself. You just got to know that pretty soon you will have paid more than you'll pay for a cycle of IVF that's going to give you a several hundredfold improvement in your pregnancy outcomes. Let's say, is going slower beneficial? And actually, I got that question as well. Low and slow is a good thing. The ideal IVF stimulation period of time is 9 to 12 days. So if you stimulate fast, let's say your follicles grow in 6 days, they may grow to mature size, but your egg quality may not be the same as someone who stims for 10 days. So we don't want to overdo it. We want to do it slow enough that 9 to 12 days is really optimum for egg stimulation. Kelsey Sass is here and says, how much can AMH fluctuate? I was tested last June and it was 1.54. Our consultation is at the end of May. Should I expect that it has changed much? I've been on keto carnivore and CNY's recommended vitamins. So, it's going to go down typically over time. If you're on birth control, that can suppress it by, sometimes even up to 30%. But yeah, it's going to go down. We're going to test it again. My guess is, depending on how old you are, at the beginning, it's still probably greater than 1, which tells me that you're likely to respond as expected for age with IVF stimulation. Hi, Mevish. Nice to see you. We just got off the phone, right? Don Deluxe says, mine was 1.1 last March, and now in April, it's 0.645. So yeah, it can't go down. Oh, hi to Devin in Key Largo. Thank you for being here this fine day. Megan says, I used Menopur and have 2 normal good grade frozen embryos now. I'm getting one of those implanted this Friday at Colorado. Oh, awesome, Megan. We will look forward to seeing you here. What if your T helper cells are shown by labs not to be high or are within range? Do you think it will still work? So I would not advise testing the T helper cell activity. That test costs generally about $1,200 and does not necessarily have a lot of clinical use. So it's much easier to treat that with a $15 medication. I'd also be a little suspicious if you say you had the T helper cells checked. Is it T helper type 1 and type 2? I suppose that if you actually did test those and their normal ratio, then I imagine Prograf is might not be a useful thing. Yeah, and Megan says here, the PIO shot is not my friend. Nope. Any tips for the week of transfer? I do want to throw this out there. 5 supplements that you should be on for embryo transfer. Your prenatal, vitamin D, vitamin E, CoQ10, and L-arginine. prenatal, vitamin D, vitamin E, CoQ10, L-arginine. I have a book I wrote on that, by the way, and it's a very nice, easy to read ebook that actually includes a discount for you if you want to buy supplements from a very reputable supplier. You can go to the link on my Instagram, which is Linktree, linktr.ee/RandyFinkMD, and you will see both the link for that ebook on how to the evidence-based protocols for supplements for egg quality, for people trying at home, for people doing IUI, for people doing IVF, for men, for people doing embryo transfers. It really covers all bases. Easy to read, nice little ebook there. It's only $7, and it will get you about a $25 discount on the supplements if you choose to buy them. So there are evidence-based protocols for supplements, and I feel really strongly about that, strong enough that I wanted to write a book about it. Also, a nice little ebook that talks, or rather, an audio book. Short thing, takes about 40 minutes to listen to, that kind of talks about some of the ups and downs of this process, some success stories, and maybe some things that will resonate with you. So I strongly encourage you to take a look there. That's my Linktree, linktr.ee/RandyFinkMD, or you can just go to my Instagram page, RandyFinkMD, and you'll see that's the link that's in the bio. Let's see what we got here. Hey to Lauren as well. NG Chapin Nichols. MG Chapin Nichols. Okay. I recently had an egg retrieval, 34 eggs retrieved, 24 mature, 9 fertilized, and only 1 was frozen at blast. What can be some of the reasons our attrition rate was so high for our egg retrieval? The first thing I would think about, and so, if we were having a consult, what I would do is I would be taking a look at your stim. I would take a look at when you were triggered. I would take a look kind of at what your baseline labs are. But the thing that jumps out to me right there is 34 eggs retrieved means that's a lot of eggs. That's a lot of eggs. And when we deal with quantity, we lose quality. So just again, off the top of my head, I would say number 1, metformin will help you with egg quality. And that's 1,500 milligrams of extended release metformin a day, 750 milligram tablet. Usually you start 1 at bedtime, and then you increase that to 2 after about a week. That will help your egg quality. It will decrease the estrogen environment in those eggs that contribute to lower egg quality. And I would probably lower your dose, because I'd be really interested in decreasing your quantity and increasing your quality. That's what leaps right out at me there. What else we got going on here today? Oh, it's about 12 minutes to the top of the hour, so we got time for some more questions. MA First says, I'm 19 weeks and 4 days with my miracle CNY baby, thanks to Syracuse. I haven't seen your name around for a while, and now I know it's because you're pregnant. You're almost 20 weeks. 3 more days, you're halfway done with your pregnancy there. So congratulations. And God, we love to hear that news. That is just the best news ever. Denise Bean said, I had my HSG and my SIS, and I was told that only told that my uterus is pushed up to the left. Can that be an issue as to why I haven't conceived? Not likely. Some people are, so you may have heard this terminology, anteverted and retroverted. There's some people, I hear that a lot. People say, well, I have a retroverted uterus, so that's why I'm having a hard time getting pregnant. And I say, nah, I don't know about that. Some people are right-handed. Some people are left-handed. Some uteruses sit forward. Some uteruses sit backward. Some are a little to that side. Some are a little to that side. And to be honest with you, it shouldn't make too much of a difference as long as the uterine cavity is normal and the tubes are open. So, Denise, I think you're probably in okay shape there. And let's see what we got. Oh, Mama Bear. Hi, Mama Bear. Let's see. Oh, back to the Facebook side. Bethany is asking, my AMH is only 1.75, and I'm 33 years old. I have endometriosis and blocked tubes and PCOS as well as hypothyroidism. Why do they want me to do mini versus standard? Well, if it were me, so an AMH of 1.75 does not, to me, equal PCOS. To me, I would rather do. I would not be doing a mini dose for you, based on what you're saying there. I would go with a little bit more of an age appropriate dose. Now, let's say that we had that same scenario and you said, and my AMH is 6.75. Then I would say, well, because your age appropriate dose for a 30-year-old, we're going to dial that down to something that might be a little more appropriate for a 20-year-old because your ovaries are going to respond much more aggressively. With an AMH of 1.75, listen, there's nothing wrong with a mini dose therapy. You're just likely to get fewer eggs. And again, we don't need you to get more than, anything more than 15 does not improve the outcomes of that cycle for you. So 15 is a pretty good number as far as I'm concerned. Yeah, that's my feeling on that, Bethany. A lot of our providers, Dr. Kiltz loves to use the mini dose and feels very strongly about it. And rightly says, there's no harm in it for anyone. You're not going to hurt anybody with a mini dose. And we would really much rather see you not having to spend all your money on medications. And so that was probably the rationale why they picked that for you. And it also may have been that they thought, well, before your AMH came back, you said you have PCOS. And so we're thinking, oh, it's going to be that AMH is going to be a little higher than that. So let's dial it down. But I think you would be appropriate for a standard dose, given what you describe. After transferring 2 high-grade embryos not tested for the first time, but both failed, do you recommend transfer 2 again or only transfer 1 the second time? Excuse me. I think some of that also depends on I guess those were blastocysts. Some of that depends on, it depends on whether they're day 3 or day 5. And it also depends on whether they are, I don't know how old you are. So increasing the number of embryos transferred does not always increase the pregnancy rate. So really a little bit more detail we probably need on that to make a good decision, okay? Linda's here with us on Facebook. Go with standard on meds. It's better to have more than not enough. Okay, that's a very practical advice there. Good. Let's see. It looks like Tommy or Tommy says, how many eggs transfer do you recommend for someone with fibroids, multiple miscarriages, and 43 years old? Frozen transfer, not testing. So if you're asking about how many embryos to transfer, at 43, you can transfer multiple embryos. And why is that? Well, because we know that at 43, a small percentage of your eggs are going to be normal. So the reason we wouldn't want to say in a 23-year-old that we want to transfer 3 embryos is because there's a very high probability that they're all going to be normal, and we don't want you to have multiples. But at 43, we know that there's a much, much smaller probability that even one of them will be normal. So you can transfer multiple embryos, even, sometimes up to 4, depending on, sometimes even up to 5, depending upon whether they're day 3 or they're blastocysts. Let's see. I have PCOS. Can I do I think that's asking, can I do IVF? Absolutely, you can. Bethany Jean, I think we answered that one. Oh, maybe I'm going backwards there. Lacey is with us. Hi, Lacey. Actually, Gabrielle asked a good question. On your website, an hour consult, $499. What's the difference between booking through CNY and through you directly? Well, so on my link tree, you can do a personal consult with me, but I do charge the standard rates for that. The other alternative, and I'm happy to talk to you whenever I can, is to book it through CNY at the prevailing rates of CNY, which are obviously much, much lower. The problem is that you may call and say, I'd like an appointment with Dr. Fink. And they say, okay, we can fit you in 8 weeks from now. Or 3 months from now is his next available appointment. So if you are paying for that other consult, then you get in pretty much right away. Let's see what else. London says, do you think DHEA will help increase follicle count? DHEA is one of the most important supplements for women with diminished ovarian reserve. And the dose for that DHEA is 25 milligrams 3 times a day. Now, usually I like to later on test that number, but your DHEA can be as high as 650, and I still say that's fine. DHEA in women with a diminished ovarian reserve is one of the top 2 most important supplements. The other is the CoQ10. So I definitely, if you have low ovarian reserve, recommend DHEA. You'll see that in the book. Again, that book, The Vitamin Victory, is on through my, you can see the link in my Instagram, but my link tree, linktr.ee/RandyFinkMD. DHEA, 25 milligrams 3 times a day, along with CoQ10, 400 milligrams if it's the ubiquinol form, or 600 milligrams, both divided twice a day if it's the ubiquinone form or the non-ubiquinol form. Okay, hopefully that helps you there. Is BCL6 part of the fertility testing? This comes from Tracy. No, that is an extra, that's a different test. And I would not recommend that you routinely do that unless we find that you're having a problem implanting. BCL6, remember, is that marker for endometriosis tested through the Receptiva test. And I do not recommend that for the general population. I do not feel like people should be doing that test before they know they have a problem. It just does not seem to be worthwhile. Linda asked, my transfer is on Thursday, and I'm really trying to decide one or two. If in doubt, generally pick one, because we want you to have one healthy baby at a time. That's generally what we're after. Hi to Dawn Deluxe there again. So if you're 39 and your AMH is 0.645, not sure where the question was there. I think that may have been a part of a different question that we lost. Can we request, Jenny asked, can we request the Prograph as part of our protocol at CNY Colorado Springs? Absolutely. Now, the folks at CNY, this has been emailed to everyone. Everyone may not have read it. So you may talk to someone in the global travel team who is not familiar with that recommendation. If in doubt, they can all just ask them to please ask Dr. Fink. They text me all day long asking questions about this and that, and I'm very happy to make sure that you get it. But yeah, Prograph is 3 milligrams a day. So it's either divided in half or 1 milligram a day. So 1.5 twice a day or 1 milligram 3 times a day. Hi to Julie from upstairs in the OR here at Colorado Springs. And yours truly, Jess, asks, how soon can I do a frozen transfer after an egg retrieval? That very next cycle, you can do it. Again, you have a period about 10 days later, and that lining sloughs off. You have rebooted the system, and you are ready to go and get pregnant, my friend. Let's see. Can you explain what ethinyl estradiol does to FSH? So you may remember a few minutes ago, I was talking about that if your FSH level is high, we want to bring it down so that the FSH that we give you will have something to do. So that, if your FSH is already high, we can't, giving you more FSH probably isn't going to help. One of the ways that we can bring that down is by using a type of estrogen that's called ethinyl estradiol. That's the type of estrogen that's in a birth control pill. Why would we use that? Well, because when we're testing estrogen in your blood, that's plain old estradiol. It's not ethinyl estradiol, so it doesn't show up in the blood test. Estrogen lowers the FSH. If the FSH is high, we give you more estrogen, that brings the FSH down. That's kind of the way that works. Imani says, I last week I asked about my low HCG. The HCG was only 2.8, told to stop meds, but my home pregnancy tests were getting darker. Thank you for advising that I continue my meds. My third beta doubled. That is awesome. Wow, that is fantastic. I can't wait to hear that story, my friend. And gosh, I can't wait to see your baby. Please send me a picture. That is fantastic news. If I don't have a period, this comes from Deja Thomas, can I still do IVF? I'm 29. So most people who don't have a period don't get that period just because you're not releasing an egg. If you're anovulatory, that means you don't release the egg, then you don't get the period. So yes, absolutely. That's one of the reasons that people will opt to do IVF. So yes, you can. Some people have what's known as a premature ovarian failure or premature ovarian insufficiency. And in that situation, well, it's much harder. That means you really don't have any of your own eggs left. And so will not really be successful with your own eggs, but you can certainly do that with donor eggs. So that's definitely worth a conversation there. Hey, folks, gosh, it's already top of the hour. Man, this one whipped right by here. As usual, I sure hope you had a good time and that this was helpful to you because I love being here with you guys. It's great to see new names every week and some of the same old names every week. Thanks for reaching out to me. Thanks for picking up my ebook and my audio book, and thanks for asking for consults with me. I'm very flattered and happy to be here as part of your journey. Speaking of that journey, remember, and speaking of books, like I always say, like the sign behind me there, which comes from Jody O, who is now the embryologist, chief embryologist in Sarasota. This journey, this story of infertility is not your novel. It is not the story of your life. It is not your book. It is merely a chapter. And what we're doing here is rewriting it together. Every foot forward with faith, with kindness, and with love, and with hope that tomorrow brings a new day. So until next week, God bless. Thanks so much for being here, and good night. See ya.